Hello, good day. My name is Arvind Rajamani. I am an intensive care consultant in Sydney, and I'm the coordinator of a very unique ultrasound training program called the Learning Ultrasound in Critical Care program. Now, it's essentially for patients who are acutely unwell. So it's for in the critical care setting. So for ICU, emergency, anesthetics, but it can be used by any doctor to learn bedside ultrasound. There are various modalities that we cover. We cover heart or cardiac ultrasound, lung, biliary and renal and vascular ultrasound. And essentially what it does is it takes a beginner from novice status, and over a period of between 2 to 4 months, there will be some supervised training sessions, and the supervision can be done over the internet, where we take the novice to competency. Okay. Now, this particular video is about how to do an echocardiogram. It is not about interpretation of the findings of the echo, but it's about how to do an echo. Before you do this, I assume that you have already watched the physics presentation that I have given, which is understanding how the ultrasound works, how the screen orientation, the probe orientation is, etc. If you have not, then stop seeing this video now, go to the physics video, and then come back to this. Now, before we start with the ultrasound, let's just learn a little bit of the cardiac anatomy, or gross cardiac anatomy, okay? Now, the heart is present somewhere along the left side of the sternum here, okay? And it's divided into the left heart and the right heart, okay? I'm going to make this a little bit bigger. So once again, somewhere along the left edge of the sternum here, and again, it's divided into the left and the right sides. Now, remember, this is a two-dimensional thing. So I can't show the depth. I can't show anterior to posterior. Now, let's talk about the right side first. The right side has posteriorly, it has the right atrium. So somewhere here is the right atrium, it's posterior. Okay. And the IVC, the inferior vena cava, will come from below on the right side of the midline and join the right atrium. The SVC will come from above and join the right atrium. Then the right atrium will have the tricuspid valve, and it will open into the right ventricle. And which color can I choose for the right ventricle? Okay, I'll choose a lighter side of blue. The right ventricle will then give, so somewhere here, it will come out, and through the pulmonary valve, it will give rise to the pulmonary artery, and the pulmonary artery will then branch off into the right side and the left side. This is all posterior, okay? The right ventricle is anterior. The right atrium and the great way and the IVC and the SVC are posterior. The pulmonary artery starts anteriorly from the right ventricle and then goes posteriorly before it divides into the right and the left. For the left side, you have the left ventricle here, okay, anteriorly. And that's the apex of the left ventricle, and this thing here will be the base of the, so this whole thing up to here will be anteriorly, it will be the left ventricle, okay? Then you have the left atrium, and which color can I choose? Maybe I'll choose purple. Okay, the left atrium will be posteriorly somewhere here, okay? It's posteriorly, and that opens into the left ventricle through the mitral valve, which is here. The left ventricle will give rise to the aorta, and this is anterior. The aorta crosses posteriorly, becomes the arch of the aorta, and then along the left side of the midline, it comes down as the thoracic aorta, descending thoracic aorta, and the abdominal aorta. Okay, so the aorta and the pulmonary arteries both start anteriorly from their respective ventricles, but then they go more posteriorly along the vertebral bodies, along the spine. So they actually arch from anterior to posterior, both of them. Okay. Now, the relationship between the right and the left ventricles is a little bit interesting. Okay. So let me get rid of all of these colors and just have the right and the left ventricles. Okay, the right ventricle it starts off, the inflow part of the right ventricle is on the right side of the left ventricle, and the outflow part of the right ventricle, which is the pulmonary artery, is slightly to the left side of the left ventricle. Okay, and somewhere here you'll have the aortic valve. I'll choose a different color. So somewhere here you'll have the aortic valve. Now, this is very, very, very important to understand, because when we talk of the various axes with the ultrasound, remember that we are only catching one slice. And the way I keep teaching ultrasound is, think of a loaf of bread. Okay, think of a loaf of bread. Now, this loaf of bread is a big, fat, three-dimensional structure, and you can slice this loaf of bread along its short axis, which is what we do, and this is how you slice. So when you say a bread slice, essentially you have a rectangular slice of bread in its short axis, and you take two slices and stick some veggies or something in between to make a sandwich. But what stops you from cutting the same slice of bread along its long axis, like this? So along its long axis, so that you get a really long slice of bread, a giant long slice of bread, and you can keep lots of veggies, and that'll be a family sandwich. Or you can actually cut it along the coronal axis. Okay, so that's the slice of bread. You can actually cut it along its coronal axis like that. And again, you can get two big fat slices, or several slices along its coronal axis. Same way for the heart, you can slice it along its long axis, along its short axis. Okay, you can have various different oblique axes. Okay, different colors for the oblique. You can have various different oblique axes. You can have coronal axis. So you can do all sorts of things depending on where you're sending the ultrasound beam and how you're sending the ultrasound beam, which direction. And we will now, over the next little while, we will see the various ways by which we can actually get the various windows, the various views. Now, I use the word windows. Okay, what does a window mean? A window is exactly what a normal window is in your house. It's a place from which you have a good view. Okay, and here it's a place from which the ultrasound has a good view of the structure that you want to see. Okay, so for the heart, given that the heart is in the precordium here, and there are lots and lots of ribs and sternum and all these things, clearly the window has to be in between the ribs. It has to be in the intercostal spaces. You can't have a window, you can't have a window on the intercostal spaces, because everything will just be black. So not over the sternum, not over the ribs. So it has to be in between the intercostal spaces. There are three classical windows that beginners are taught. There are other windows as well, but there are three classical skin locations which beginners are taught. The first location is called the parasternal location. I'll choose a different color. The parasternal location. It is on the left sternal edge, somewhere in just to the left of the sternum. The second is called the apical window, and it is somewhere near the left ventricular apex. Okay, you keep the transducer somewhere along the left ventricular apex. And the third window that we teach is the subcostal window, where the probe is kept somewhere just below the xiphisternum, or the sternal notch, and ideally over the liver. So this is the liver, over the left lobe of the liver. There are other windows as well. You have something called a suprasternal window, which will be somewhere over the suprasternal notch, but these are not things that are taught to beginners. From each of the windows, the ultrasound beam orientation can be in various different ways. Okay, so from the parasternal window, you can have the orientation of the beam going along the long axis of the heart, or along the short axis of the heart. From the apical forechamber, you can get a coronal axis of the heart, so this one, okay, a coronal axis of the heart, or you can get what is called a two-chamber, which is an anterior to posterior axis of the heart, like this. From the subcostal window, again, you can get what is called a coronal axis of the heart, so you can get it sweeping, dividing the heart anteriorly and posteriorly, but you can also get a window that is very similar to the short axis in multiple different planes. So you can actually rotate the probe and orient the probe in various different ways from each window. But classically, these are the three windows that we teach beginners, which is the parasternal, okay, the parasternal, which is somewhere here to the left of the midline, the apical, which is from the apex of the left ventricle, and the subcostal, which is just from the xiphisternal. Now, one of the first decisions that you have to make when you start an echo and want to do a parasternal long axis view of the heart, for example, is where am I going to place the echo probe on the chest? Okay, where are you going to place it? If you read the textbooks, what they will say is you take the probe, keep it somewhere in the third intercostal space or the fourth intercostal space, and the probe marker must face the 11 o'clock position. Okay, and if you do that, you are expected in every single patient to get this axis, which is the long axis of the left ventricle. Okay, now I'm going to tell you that you are actually not going to get a good view in most patients by just simply keeping the probe in the third intercostal space towards the 11 o'clock position. To demonstrate that you cannot get it in most patients, just do this simple experiment. Take out your credit card or a visiting card or something that is thin. Okay. Then move away from the screen by about 2 or 3 steps from this computer screen. Then close your eyes, walk back to the screen, don't touch anything else, just have the credit card in your hand, and then blindly, without opening your eyes, just keep the credit card somewhere on the screen, the edge of the credit card or the visiting card, somewhere on the screen, and see whether how it aligns to this purple line. Okay, how this is the purple line is the parasternal long axis. See whether you can automatically keep it in alignment with this purple line. Okay, you will not be able to align it perfectly. If you're able to align it perfectly every single time, then please buy me a lottery ticket, because I think I'll become a millionaire. You are so lucky. Okay. Now, what is the point I'm trying to say here? When you have your patient, unfortunately, the patient's heart is not visible to you. The patient's heart is being covered by skin and bones and skin and everything. In fact, I should actually cover it like this. Okay, you don't know underneath the skin whether the patient's heart is straight like this, or whether it is angulated like this, or whether it is pushed to the right side by a big pleural effusion on the left. You don't know any of these things. How can you just keep the probe in this how can you keep the probe in the third intercostal space, aim it towards the 11 o'clock position, and expect that all of a sudden in every single patient you're going to get a good view? You cannot. What is the better way? I'm going to teach a lucky way, which is the luck way of getting that same thing. When you have a patient who's lying down supine, the patient's heart is going to be somewhere in this area. Okay, now where exactly the patient's heart is depends on a number of things. Usually it's present somewhere here, just to the left of the sternum. Okay. However, when you have a huge pleural effusion, okay, so assuming you have a huge pleural effusion on this side of the chest, what happens is that the patient's heart will get shifted to the right side and the patient's heart may be here. Or the other thing could be that the patient's heart has you have a big collapse of this lung, and therefore if the patient then again what will happen is that the patient's heart will move towards the left side, and it can be somewhere here, or it can sometimes even be here to the right side. Okay. Now, if the patient, on the other hand, has a big pleural effusion on the other side, so here on the left side, then what will happen is the heart will be shifted to away from the sternum. You don't know. Okay. Conventional teaching is you keep the probe. Okay. You take the probe and you keep the probe in the third intercostal space facing the 11 o'clock position, and bang, you're expected to have the parasternal long axis of the heart. Okay. However, that entire thing depends on the presence of the heart in this axis just to the left of the sternum. Because we don't know that, and especially in critically ill patients where anything can happen, and even in normal patients, you can have the patient's heart in a completely different orientation. Instead of the patient's heart being oriented from the right shoulder to the left hip as normal, you can have an orientation like this. You can have quite a vertical heart. In COPD patients, for example, the heart is like this. Okay, so when you do this axis, when you do this 11 o'clock to 3 o'clock axis, 11 o'clock to 4 o'clock axis, you will not get a good parasternal long axis. So the first thing is to identify the plane of the heart. Okay, and this is for any ultrasound, not just for cardiac echo, it is for any ultrasound. Okay, so what you do is you don't know what is there under the skin. Okay, so the step one is always just keep the probe in the direction and the plane that most people have. Okay, but deliberately go to an area where you do not expect the heart to be. Okay, so for example, keep it somewhere here where you don't expect the heart to be. And then for the parasternal long axis view, you go down slowly, 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 slowly in a vertical line along the left sternal edge till all of a sudden you get some glimpse of the heart. Okay, so you'll get something here on the screen. Keep going down even further, cross that, and you lose that image. Then you go back up and get back the image on the screen. Okay, get back whatever image you have of the heart on the screen. Then you start doing some fine tuning. Okay, and I think in the physics thing you've already learned how the ultrasound image is constructed. It is essentially one single slice. So what you're seeing on the screen is essentially, if you have this structure like this, okay, you are essentially cutting one single slice of it. So if you think of a loaf of bread, if you have such a big loaf of bread here and you are going to take one slice in its short axis, you don't know whether the loaf of bread is spoiled distal to it and proximal to it. All you know is that particular slice. And therefore, if you want to know whether the whole bread is fine and good enough to eat, you actually have to take lots and lots and lots of slices everywhere. Not only that, you may have to take slices in the opposite direction. So that's what we are doing with any form of ultrasound. We get for the same heart, we get multiple planes, one from the parasternal edge. Then we rotate and get the transverse axis, the short axis. Then we go to the apical forechamber. Then we go to the subcostal. And essentially, you're seeing the same structure, but from different angles. And what you're doing is you're getting different slices. You're interrogating all these slices. Okay. So in order to get the parasternal long axis, this is how you do. You go where you do not expect the heart. Okay. Then slowly, 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 you keep going down. You start getting some part of the heart in the screen. Then you go down further, you lose it, you come back. And then now what you're trying to do is
you want to know, okay, where exactly my heart is, this patient's heart is. So you don't know where, so you want to map the heart somewhere here, okay. So assuming you've come somewhere here and you get what you think is a reasonable view of the heart, okay, but it doesn't seem to be the perfect axis. Instead of nice and long, it is round or something. What you now do is you start doing some various fine tunings. Okay, so now let's go and see how we do the fine tuning. Okay, now this is the shape of the heart. Okay, this thing here is the left ventricle. Okay, on the right side, but anteriorly, somewhere here, you have the right ventricle. Okay, then a little more posteriorly, you have the right atrium, and a little more posteriorly on the left side, you have the left atrium. From the left ventricle, you have the aorta coming out, okay, and the aorta comes out like this. And from the right ventricle, okay, I'll choose a different color, maybe the blue, you have the pulmonary artery coming out, and the pulmonary artery arches like this and then goes to the two sides of the lung. Okay. Now, what we are doing with ultrasound is we are going to cut this heart or slice this heart into various different slices. And the heart, so for example, this is the parasternal, this is the long axis view of the heart. Okay, so how the image will be constructed is it will go from the most anterior or the most superficial to the deepest. Okay, so it'll be a slice like this. So if I'm cutting open the heart in this axis, when you open it on the screen, you will have, okay, you'll have a superficial edge, then you'll have a middle and a deep edge. Okay, now you can cut the same heart from a different plane. You can cut it if you keep the probe along the apical fourth chamber, for example, from the apex of the heart. You can actually cut a broad line. Okay, you will cut it along this axis. Okay, and you will have what is called a coronal slice of the heart. So if you think of a CT scan, when you do the CT, the classical, all these are called the axial sections. So this. So cutting a slice of bread, classically we cut it in short axis. A loaf of bread, the slice of bread is in the long, is in the short axis of the bread loaf. Okay, if you want, you can actually take a long axis that is called the sagittal section, okay, of the CT scan. So you can cut that same bread loaf into the long axis. You can also have a coronal slice of the bread. So you can have lots of different long slices in the coronal plane. You can have oblique slices. You can have various different slices in between these various things. Okay, you can do exactly the same thing for ultrasound. Not just heart, any ultrasound. What we want is something that is described in the textbooks as standard views. The non-standard views are fine. They are also views of the heart. So if I give you a loaf of bread where I have completely oblique slices and I give it to you as a sandwich, will you not eat it? Will it taste different? Okay, but when we think of a sandwich, we think of those axial, the short axis views. Okay, now the other views are also equally okay. They're all part of the heart. But if I say I had 2 slices of bread today for, 2 slices of toast, and immediately what you will think is I had 2 slices, 2 short axis slices of a standard loaf. Okay, if I told you on the other hand that if I had 2 coronal slices, that will be equivalent to 4 of the short, or maybe even more. Okay, so that is no longer comparable to the standard. Okay, we have all these standard views. These standard views are called the parasternal long axis view, the parasternal short axis view. Then we have something called apical views, and we have something called apical 4 chamber, which is the coronal view. The apical 2 chamber, which is a sagittal section of the heart, and an apical 3 chamber, which is a slightly oblique view of the heart. Then we have something called the subcostal view, which is again a coronal view. Then we have subcostal short axis views, which are again short axis or sagittal sections. Okay. Now, if the moment I say I did a parasternal long axis, immediately you know that the standard view must have this and this and this and this. So therefore, for each of the views, for you to compare your echo with Chris's with mine, we need to try and do the standard views. However, when you see pathology that is occurring in a non-standard view, please take that as well, because that is also important. Okay, you have classical standard views, but you also have other views that are quite standard but which are not taught at a basic level. Unfortunately, when you do the ultrasound, your ultrasound probe will get all sorts of non-standard views or standard views that we don't teach. So what I'll be doing as for LUCC is, not only will I teach you the standard views that we teach everybody, but also many of the views that are perfectly acceptable, but things that are not taught conventionally, I will ask you to do them. Okay. So example. For the parasternal long axis, okay. For the parasternal long axis, this is the left ventricle here, okay. Now this, so if you divide the heart into two, it won't be two equal halves. It will be the left side, about 2/3 will be the left side and about the 1/3 will be the right side. Okay. So this is going to be the right atrium posteriorly, okay, and the right ventricle anteriorly and to the right. Okay. So when you take a parasternal long axis view, I'm changing the color of the probe all the time. Okay. Now this is where you want the probe to be. This is the angle. Okay, this is along the left ventricle, along the aorta. Okay, along the aorta, and then posteriorly you will have the left atrium posteriorly to the aorta. This is your, and then in between here you have the mitral valve. This is your classical long axis view of the parasternal long axis view. So parasternal long axis view. However, if you have the probe facing, instead of facing exactly over that, if you tilt the probe slightly towards the right side or the right hip slightly, what will happen? All of a sudden, you will get the same view, but you will get the ultrasound beam will go towards the right side. And you will now get the right atrium and the right ventricle. This is called the parasternal long axis view of the right ventricular inflow tract. This is a perfectly standard view that we get for the right side, but we don't really teach this for beginners. But it's so common that you get this and you don't recognize it. So you have to know how to recognize it. Now, the right ventricle, another thing that happens with the right ventricle is the pulmonary artery comes out of the right ventricle and then it actually curves around the left ventricle, okay, and then forms the right and the left pulmonary artery. Now, if you now have the probe facing, the probe facing the left shoulder, what will happen? You will suddenly, so if you have, so let me take this off, okay. If you have the probe facing the left shoulder here, so you get, sorry, not this one, you aim towards this side, you can have the parasternal long axis view of the right ventricular outflow tract. This is exactly. So the right ventricle, the way the normal heart is that the right ventricle actually wraps around the left ventricle, and this side is the inflow tract here. This is the inflow tract and this is the outflow tract. Okay. So the right ventricle actually wraps around the left ventricle throughout. So on the right side of the heart, you have the right ventricular inflow tract. On the left side of the LV, you have the right ventricular outflow tract. Okay. Now, it is extremely common, particularly in patients with a dilated right ventricle. So patients with COPD, etc. When you keep your probe here and you expect the parasternal long axis view of the left ventricle here, instead of that, what will happen is when the right side is dominant, it is quite common for you to get a view through the right side. So you should know how to recognize it. And what should you do to correct it? Yep. All you have to do is either tilt it to slightly to the left side, or move the probe, slide the probe slightly to the right side. Okay, so you have to know how to recognize that. So for each of the views, you have to know how to recognize a good view, an oblique view. So I'll give you an example of an oblique view. Now when you keep the probe, you expect it to go through the LA and the LV like this for a parasternal long axis view of the left ventricle. However, if the heart is slightly shifted in the chest because of normal variation of anatomy or because of a pleural effusion, something like that, that same orientation that you have kept may get a view like this. Okay, a little bit of the right ventricle, a little bit of the mitral valve here, a little bit of the left ventricle. And what will be the shape of the left ventricle here? It may be round or slightly oval instead of nice and long. So think of your bread loaf again. Okay, if you don't have a nice sagittal view, which is nice and long and cylindrical, if you have an oblique view, it will not be cylindrical. It'll be in between the short axis and the long axis. It'll be an oblique axis. So what should you do? What should you do here? So instead of being like this, so you have to turn is called rotate. So you have to turn the probe to the right side, and then that will correct it. So this is what you do. Okay. So step one for doing an ultrasound is always just find the structure that you want. This is called finding a window. Okay. So now let's do this. I want you to now see. Okay. I want you to see 101. How are you going to do that? Find a window. So the skin is covering it.
So I guess I'll start.
You can do whatever you want.
So as in, am I using ultrasound?
No, you are actually, I want you to see him.
So I have to change my window, so I can stand, I can go this way, go underneath, go around.
Exactly. So that's exactly what you do. So first step is you want to get the heart. You just want to see where the heart is. So what you do for that is, so this is the sternum, okay? This is your diaphragm, okay? Okay, what you first do is just keep the probe somewhere in the precordium, depending on what your view is. So if this is for the parasternal long axis view, just keep it to the left of the sternum in a direction that you expect for most people, which is something like the 11 o'clock position, and deliberately keep it very high up where you do not expect the heart to come. And then what you do is you just slowly keep sliding. Okay, and as I said, keep sliding till somewhere here you will find a beating structure. Don't worry about this, how it looks, whether it's a long axis, short axis, oblique axis. At this stage, all you want to do is to find a beating structure. Okay, keep going down. You are now mapping the presence of the heart in the precordium. Okay, so here, when you keep it here, okay, the heart is low, well below. When you keep it high up, what do you expect to find? What structure will you have in this part of the chest? Somewhere here. No. Exactly. So here, the purple thing is the lung. So here you should expect lung. So it's normal lung, or normal or abnormal lung. You'll find lung. So as you keep going down, 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 you will continue to have lung, lung, lung till all of a sudden there will be an interface where you'll have part of the probe will be the lung, part of the probe will be the heart. Keep going down further, you'll have only the heart. Keep going down till you lose the heart, go into the abdomen. Then go back up and find the heart, and then that's one. Second, okay, second experiment, okay. I want you to see him, okay. So can you see Gunawan?
Yeah.
Through this?
I cannot start to go down or
Okay. Okay, what about now? This is a little bit. Okay, so can you see him?
So I can see this angle.
Okay, can you see him really clearly?
No, it's blurred.
Why? Because the window is not good enough.
Yeah.
So once again, it's the same thing. You can see a little bit of him,
Mhm.
but you can't see it well enough. So what you're going to do now is you are going to go around this. Okay, if this is the only window, the first thing is, okay, what you can do is get rid of things that you can get rid of. So if you have this, an ECG lead, for example, you don't need that in the precordium when you're doing the echo. Take it off and put it elsewhere. So just like how for a surgeon, he'll have everything clean around the surgery. When you're doing a central line, you have a wide area that you have no obstacles. Whatever you can remove, get it out. Okay, so get this out. Now you're able to see better. Okay. Second, if it's very blurry, what you now do is press hard on the skin, and often you'll find that if you just press on the skin, will improve the image. Okay, dig deep. Obviously, you don't want to hurt the patient. We tell everyone that ultrasound is harmless and doesn't cause any pain, but the answer is can be hurting, and especially ribs can hurt. Okay, third, move medially and laterally, this direction and this direction, and all you have to do sometimes is just move a millimeter or two one side or the other, and then change the angle a little bit. All of these things will give you a good image. Okay, so get a good window, then start interpreting your window. Is it a good parasternal long axis? Okay, now for a good parasternal long axis view of the heart, you have to have, oh, this is the image, this is the screen. Okay, so the screen is a rectangular screen, and the phased array or the cardiac probe will have a shape like this, like the green one here. Okay, now in that, always try to have the structure of interest in the center of the probe. So the center of the probe is this point here. Okay, so for the parasternal long axis, you have to have right ventricle, which will be round, followed by interventricular septum, and then the aorta. The left ventricle cavity is here. This is the left ventricle here. Okay, this thing is the aorta and the left atrium. And in between, you'll have a couple of valves. And what I teach people generally is that the center of the probe must intersect the annulus of the aortic valve and the annulus of the mitral valve. Okay. Second, the cavity of the left ventricle, okay, sorry, the walls of the left ventricle, which will actually be the same as the wall of the anterior wall of the aorta and the posterior wall of the LA. Now they'll be a sort of a semicircle arc, but they must be parallel to each other. So the right ventricle must be right, nice and round, or sometimes it can be a flattened oval like this. The left ventricular cavity must be long, like a cylinder, and the two walls of the left ventricle, the anterior wall of the aorta and the posterior wall and the posterior wall of the left atrium, must be parallel to each other in an arc. Okay, you can have various configurations of wrong axes in this. If you have the right ventricle inflow tract view, so once again going back to that image, so right ventricle is here, okay. If your ultrasound beam is going across the right ventricle here, what you will find is, instead of the right ventricle being nice and round or a flattened oval like this, the right ventricle, the posterior wall of the right ventricle will not be seen. It will open up and it will be in its long axis, and you'll have the tricuspid valve in between. So you'll have the RV, the RA. So anterior, this is anterior, this is posterior, okay. So the RV will open up, and the RA, you can see the RA, RV, and the tricuspid valve. Okay. Then the other thing that can happen is, so that's your left ventricle. If you have an oblique axis like this, now what you'll find is that, okay, this is anterior, this is posterior, okay. If you have an oblique axis, again, what you might find is that the right ventricle could potentially have something in its long axis, but then you'll see a little bit of the left ventricle somewhere here in an oval form. Okay, so these are the various things that you can find when you keep the probe the first time. Okay, so first time, find the heart. Second step, find out what your axis is, and then do some corrections. Okay, so what will you do for this to correct this? You will rotate clockwise, and now you will get an angle that is like this. Okay, this is the angle, and that will get corrected. Okay, so it's as simple as that, but as difficult as that. So you understand. So first, just get the heart, some part of the heart, that's fine. Second, understand the axis. Okay, now how do you change from a long axis to a short axis? Okay, so changing the axis from long to short. So in this instance, the parasternal long axis to a parasternal short axis. Again, you think of your loaf of bread. Okay, this is your loaf of bread. So far, what I have taught you is, I have asked you to cut that loaf of bread in the long axis. Okay, like this. Okay, cutting it this way. How do you cut it in the other axis? How do you change from the long axis, which is how you've been cutting, to the short axis? What do you do, Chris?
Rotate 90 degrees.
Rotate 90 degrees in this instance. Okay, but again, this is what is classically taught in the textbooks. It will say you start off with the long axis, third intercostal space, aim towards the right shoulder, and then rotate 90 degrees. Now, first thing I told you is, there is no such thing as third intercostal space, right shoulder. That depends on the patient or the human being. Okay, so you always have to search and get that. So get these surface landmarks off your head, this so-called third intercostal, nothing like that. Just start very high up, keep on searching for the heart, lose it, come back, then start adjusting the angle of your probe. Okay, so once you've got that, then again for the short axis, you start rotating clockwise, but not necessarily 90 degrees. When you say 90 degrees, you are assuming that your long axis is perfect. Sometimes your long axis may actually not have been perfect, and what you thought was a good long axis was maybe 20 degrees off axis. So if you rotate 70 degrees, you'll get a good short axis. So what do? You rotate very, very gradually, extremely gradually. So what you do is, start off here and then slowly and always rotate with your non-scanning hand. Okay, so what you do is, you mind holding the heart for me? Yep. So what you do is, this is my scanning hand. Okay, this is my scanning hand here. I will stabilize the probe with my scanning hand and take I'm a left-hander, so for scanning. Okay, so this is how I'm scanning. With my right hand or non-scanning hand, I will slowly rotate. My left hand is stabilizing the probe on the skin so it doesn't move, and I slowly rotate it. And when you rotate, what you have to do is before you start rotating, center the probe on a structure that is important. For example, okay, this is your long axis, okay? This is your aorta, this is aortic valve, and this is the mitral valve. What I will do is, I will center the probe on the mitral valve, maybe, okay? As an example, it can be anything. As you start rotating, what should you expect with that mitral valve? Should it go away from the screen? What will happen? It will slowly start changing its shape. If it goes away from the screen, what does it mean? You have moved your axis. What you do is you stop rotating, get it back by changing your axis, and you might have to tilt up and down, get it back, then restart your rotation. And if you follow this simple rule, I have a structure that I started with in one axis, one plane. I want the perpendicular plane, okay? So when I'm rotating, I'm going to rotate in such a way that I'm never going to lose that structure from the screen. I will only have that structure change its shape, okay? And if I lose it from the screen, I stop, get it back by tilting here and there, or maybe moving 1 millimeter or 2, then continue the rotation. And when will you finish rotating? So if you go back to your bread analogy, okay, so this is your loaf of bread, okay, you want to cut, instead of cutting the bread in its long axis like this, you want to cut it in its short axis like this, okay? So you will have, as you cut it, you will have various oblique axes, okay? You'll have various different oblique axes of the bread, and you will stop when you will get a perfect short axis of the bread. For the ventricle, on the other hand, you will stop when the left ventricle is beautifully round and the internal structures are symmetrical. So if it's the mitral valve view, the mitral valve is a fish mouth like this. It must be like this, okay? If it's a papillary muscle view, it must be one papillary muscle here and the other papillary muscle looking equally good, okay? Now, what if you find that on one side you have a papillary muscle and on the other side you have the mitral valve? What does that mean? So that's the heart, okay? You want a view here along the papillary muscles, but you're getting one view of the one papillary muscle, and on the other side you're getting the mitral valve. What does it mean? You are what axis is this? Is it a short axis or an oblique axis? It's an oblique axis. So maybe you have cut it like this. What do? You rotate more, or maybe you have rotated too much and you go unrotated, something. So you just continue the rotation. If it improves and this side's papillary muscle also comes, you're on the right track. On the other hand, as you're rotating, actually it becomes even worse. You go back. Okay, that's all. Okay, that's all. So important thing, never lose the structure that you started with. It can be any structure. So for the long axis, you can focus on the aortic valve, or I generally focus on the mitral valve. But that structure must be in the middle of the probe to start with. Okay? Because the middle, so when you have the probe here, okay, and this is where it comes from, okay, if the mitral valve is on one side of the probe, when you rotate, that will go away, because all of a sudden, now the only reason the mitral valve is even seen here is because one edge of the probe is catching the mitral valve here. As you rotate, you are going to change the axis of this probe, and it's now going to become like this. So this will be the new axis of the ultrasound. So the mitral valve will not be seen at all. So you have to, therefore, firstly, you have to, If you want the mitral valve in its short axis, you have to first get the mitral valve into the center of the probe. And how will you do that? By moving the probe or sliding the probe or tilting the probe slightly. So tilting the head of the probe this way. So first get that mitral valve from one edge of the screen to the middle. Then you start rotating, okay? And now you'll find that even after you complete your rotation, you will still have the mitral valve. Now, if you want the papillary muscle, then you will have to fixate the papillary muscles in the center of the probe. So instead of the papillary muscles on one side, you bring the papillary muscles to the center of the probe. Okay. In reality, what we do is this is your long axis. Okay. So you get something in the middle of the probe. You start rotating, get that structure in its short axis, and then what you do is you just tilt up and down to get the other structures. Okay, so this is the parasternal long axis. Now let's go and do it on a patient.
Now the next 4 videos are a demonstration of the hands-on. So what we are going to do is to take a volunteer and do an echo demonstrating what we have already learned so far. When we do that, we are not going to concentrate on interpreting the image. All we are going to concentrate on is acquiring the image. The interpretation of an echo is a separate thing altogether, and there are a series of videos that are part of the LUCC program. So for the next 4 videos or so, all I'll be teaching you is how to get a good image and how to identify whether or not the image is good enough. Okay, we'll be doing the 4 standard views, namely parasternal long axis, parasternal short axis, apical views in which you have apical 4-chamber, 2-chamber and 3-chamber, subcostal views where you have the subcostal 4-chamber and the subcostal short axis views, including the inferior vena cava.
The first thing is how you position the patient. Now, the cardiologist, what they would do is they'll position the patient so that the heart gravitates towards the left. Okay. Now, this will be nice if it's ideal, but in critically ill patients, it may sometimes not be possible to position the patient. So I would just do it in any position the patient is in, even if sometimes they are in the right lateral position to some extent, even then, okay? I very rarely change the patient's position right at the beginning, okay? But depending on if I don't get good enough images, then I do try and change the position. That's number one. Second, I try to map out the heart, okay? So just like how we start off, pause please, we want to map the heart. Now, sorry, even before that, for every cardiac echo, you must always put the ECG on, because most machines, they will record the cycle using the ECG. And if you don't have the ECG on, what that will mean is often you'll have good real-time images, but when it stores a loop, it may store a loop like this. It may misinterpret the muscle artifact or the movement artifact to be a cardiac cycle, and you'll have something similar to a ventricular fibrillation, and you can't interpret it at all. Okay, so always have the ECG. That's one reason. The second reason is the timing of the cardiac cycle. Often you need the QRS complex, okay, to determine which one is systole and which one is diastole. You can do it without ECG, but ideally it'll be nice to have that. We often use the ECG for that. Now this is a GE Vivid Q machine. Now I'm not really going to go into the specifics of the machine because each machine is different. It's like driving a car. Whether you have a BMW or a Kia, you finally have, you need to know where the accelerator is, the brake is. So for each machine, you just need to know where the 2D button is. Okay. then where the gain is, so in this machine this is the gain here, where the depth is, and then the M mode button is. So that's, you need to know some basic things. Can you pause please? Okay. The next thing is understanding the probe. Okay, in every machine the probe has two sides. Okay, one is where the marker is, the probe marker, which in the GE machine it comes with a light as well. In many of the other machines there won't be any light, you'll just have a groove. Okay, this is important because this side, in the orientation, you'll have one part of the screen where you have a marker, screen marker. And the screen marker essentially is the same side as the probe marker. Okay, this is something you would have seen in your physics video. Okay, now this is always superficial, this is always deep, and the orientation therefore depends on where you keep your probe. So if you keep your probe from anterior to posterior, then the superficial will be anterior, the deep will be posterior. If you go from the flank, then the superficial will be the lateral and the deep will be the medial, or the right side and the left side. Okay, then these two sides are the probe marker, and I just call it the anti-probe marker. That's just my terminology. Okay, now for the parasternal long axis view, what we want to do is have the gel, okay, and the probe marker I will generally have, I'll expect Gunavan's heart to be somewhere here. Okay, this is my expectation. Therefore, I'm going to keep the probe in this direction, between the right shoulder or the right mid-clavicle to the left hip, somewhere there. Okay, so as I said, I'll keep it, it'll be cold, so I'm going to keep it slightly high up, and I'm now going to map his heart. I don't know where your heart is, so I'm going to start mapping it. So firstly, as I'm coming down, this is a beautiful lung. Okay, this is a pleura. Then I'm now coming down, 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 down. As I'm coming down, I'm getting an image of the heart, but what you can see is the bottom 12 centimeter is unnecessary. Okay, so optimize the depth. For the first screening image, have a depth that is about 5 or 10 centimeters deep to the structure of interest, and I will store this. Okay, but from the next image onwards, focus on the structure of interest. So the structure of interest here is, if that's the structure of interest, I'll have a depth just deep to the pericardium. So now I have much better detail. Okay, so now what I'm going to do is, as I said previously, I'll go down, 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 till I lose it. Okay, and then I come back up to the place where I think I had a good view. Okay, so here. Now next is, I will try and optimize the image. Okay, I'm going to try and optimize the image. So I forgot to say how I hold the probe. The way I have been taught is to hold the probe between these two fingers like this, and stabilize the probe with the other fingers. Okay, so once again, these two fingers go and hold the base of the probe, and they actually rest the hand on the patient's skin, and the other two fingers will stabilize the probe. So this actually gives a good amount of stability. The probe won't move. So now I'm going down, I've lost the image, so I'm going to come back up, 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 up in that area. Okay, and now I'm going to see where I get an image that everything will be nice and perfect. Okay, so what I want is, if you focus on the screen, and Gunavan, you can see the screen as well. What I want is, this structure here is the most superficial structure, and that's the right ventricle. Okay, the right ventricle must either be round or it must be a flattened oval. Okay, then you have the interventricular septum, and this is the left ventricular cavity, and the left ventricle must be nice and cylindrical. Okay, now do you think that right ventricle is round or flattened oval? I'll increase the gain. Okay, what do you think? See how it's almost oblong like this, like a okay, and second, look at the shape of the left ventricle. Is it nice and cylindrical? And you should actually not be able to see this apex contracting. Okay, so that means, what does that tell you? This is oblique, this is also oblique. So therefore, what I am getting is an oblique slice. Okay, so what should I do? I have to choose a different plane. So what I'm going to do is I'm just going to move up and see. See, I've gone up a little bit, one intercostal space up. So Chris, if you can focus on the camera again now here. What I've done now is, from that image, I've deliberately gone up superiorly one intercostal space. Okay, what do you think now? Is this nice and round or flat and oval, the right ventricle? What do you think? What about the left ventricle? Is it nice and cylindrical? Okay, can you see the apex? See the apex, it's contracting. Even now, it is still not completely cylindrical. I'm going to go up one more intercostal space and see what's happening to this here. Sorry? It has become long. See, it's become long. You can't see the posterior wall anymore. And can you see this structure here? Sorry, 1 minute. Can you see this structure here? That's the tricuspid valve of the. So that's the right ventricle. That's the right ventricle. Okay. That's the right atrium. Now it's on one edge of the screen. Which edge of the screen is it? It's along the screen, the probe marker. So what should I do if I want to bring this? Now, just for teaching purposes, I want to bring this structure to the middle of the screen. Which way should I move? Should I move towards the probe marker, or should I move away from the probe marker? Towards the probe marker, because this structure is very close to the probe marker. So the probe marker is facing the 12 o'clock position. Okay. So if I move up a little bit, I should be able to get that structure moving from here to the middle of the screen. Okay. Now can you see what view is this? It's the right ventricular inflow tract view. Now inflow tract is on the right side of the body. The outflow tract is on. So what should I do? And look at the left ventricle. The left ventricle is almost round here. Okay. So what should I do? I have to now remember what I told you about the inflow tract. It's on the right side. So I have to tilt the probe slightly towards the left shoulder, and now I'm getting a little bit of the left ventricle. Can you see that? Yeah. Okay. Now it's still not round. So it's still not long. Sorry, it's not cylindrical. So what could it be? That can be, maybe I have to rotate. Maybe if you think of the loaf of bread, what I want is a long slice of the loaf of bread. I'm always getting an oblique slice. So maybe I have to rotate. So I'm going to rotate to the left side or the anti-clockwise, and see how when I do that, this has become long. So this is how you construct an echo. You do not memorize things like third intercostal space, 11 o'clock position or something. Okay. You always get firstly, map the echo. Okay, map the heart. So firstly, so here it's lung. It's lung here. Okay, go down, heart is beginning to come. Go further down, heart is beginning to come. Go further down. Now this is as you go down, can you see how the apex of the left ventricle has come in the middle? So your apex is somewhere here. And with that, I'm already catching the apex. So now for the parasternal long axis view, this is the LV apex, And this here, where you have the big vessels and all that, that's called the base of the heart. There's no reason why it should be called the base. I think because this is called the apex, that's other side is called the base. The parasternal long axis view is along the base of the heart. If you start seeing the apex of the left ventricle, it means you are too inferior. You are somewhere here. You want to be, this is where you want to be. Okay? So that's how you get the long axis, by firstly going right up. So firstly hold the probe in such a way that you know, most people it will be the long axis. So somewhere along the 11 o'clock position the probe marker faces. Go inferiorly, very slowly along the left sternal edge, and then see, if you want, you can actually stop here because this is a perfect long axis. Just for teaching, what I generally do is I actually go 1 or 2 spaces below because I deliberately want to find if there is a better window elsewhere. Okay, but having found it, I go back up and then I make sure that the walls, that this is, the right ventricle is nice and either round or a flattened oval. The left ventricle, the wall should be parallel. Can you see how towards the apex especially, it's not parallel, it's coming together more. And so that's what you should do for that, is just rotate a little bit. And as I'm rotating, what's happening here? What's happening here? What is this? That's the tricuspid valve, and see how round this has become. Okay, I've got the inflow tract view inadvertently. If I've got the inflow tract, what should I do? I should tilt the probe slightly to the left side. So Chris, if you can just focus on this now. So I've got the inflow tract view, which is this angle. So slowly, as I'm tilting, I'm going to use my right hand to show how I'm tilting. So I'm tilting the probe slightly to the left, and I get the long axis of the left ventricle. If I do the other way, if I tilt towards the left shoulder, I'll get the outflow tract view. See, that's the outflow tract view. And how do you differentiate? Look at the valve. The valve here is opening towards this structure. So this is, see, this is the inflow tract view. And the valve here is opening towards the right ventricle. So that's why this is the right atrium, this is the right ventricle, and the tricuspid valve is opening towards the right ventricle. On the other hand, here, if I'm tilting towards the opposite side and getting the outflow tract view, see how this valve is opening away from the right ventricle, and that's opening into the pulmonary arteries. Okay, right. So this is how you get the long axis. Okay, now, if you're very experienced, this is how fast you can get it. You start high up, just move there. Okay, in the beginning, you'll take your time. You'll go slowly, search, and don't hesitate. The biggest mistake that people do in the beginning is they just get stuck at one point. Don't get stuck. Just go anywhere, all over. Okay. So see, I have a good view here. However, Chris, what is wrong with this? What can you see here? And what do you see in the RV? You can see a little bit of the tricuspid. Can you see a little bit of the tricuspid? So again, that just means I've tilted too much towards the right hip. So I tilt slightly towards the left, and that's it. That's enough. Okay. So if you see experienced people, they'll just keep the probe and they'll get a good parasternal long axis. You'll take time. Now the short axis. Okay. So we have already established that. Okay, you can stop and.
Not pausing.
Okay, stop, and then the short axis view. We can do it separately. Short axis. Now, for the long axis, we know that this is one's long axis here. Okay, somewhere here. The short axis, therefore, must be somewhere here. Okay, and we generally rotate in such a way that the left-sided structures will be on this side of the screen, left side of the screen, and the right-sided structures. So that means that the probe marker will be rotated towards the left shoulder. Okay. So firstly, always before you get any change, before you make any change of axis, get your original axis. So once again, hold the probe between these two fingers, rest it here, slowly, 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 I'm getting the long axis. Then what did I say? Center the probe, center it in such a way that the center of the probe is over structure of interest, anything. In this instance, I'm centering it in such a way that it's somewhere over the mitral valve annulus. Okay? So now what I'm going to do is I'm now going to start rotating with my, I'm going to hold the probe with my left hand, start rotating towards the clockwise direction with my right hand, and as I'm doing it, I want you to see what happens to the shape of the heart. So this is now long, this is a long left ventricle, okay, and the center of the probe is over the mitral valve annulus, okay. As I am rotating, I don't want that mitral valve annulus to disappear. It should just change its shape and become fish mouth kind of thing. So rotating, starting the rotation. Can you see how the left ventricle is now beginning to become rounder, 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 and the mitral valve has never left the screen. It's still there. Okay, I'm doing it gradually. It's just changing its shape, changing its shape, changing its shape, changing its shape, changing its shape. Okay, now this here, this is where I've ended up. Okay, but can you see how towards the end, one part of the cycle, it's almost as if the jaw, the low, if you think of a smiley face, the lower jaw is just okay. Okay, that's not the true mitral valve level. This is the anterior leaflet. You can't see the posterior leaflet of the mitral valve. So what I'm going to do now is tilt the probe towards the left ventricular apex gradually, and that's your mitral valve level. Is it perfectly symmetrical, Chris? No, because see, this commissure is seen closing and this commissure is fully open. So now I have to complete my rotation. Okay. So I'm just tilting and finding the, okay. Is it better now? I'm rotating more and more and more. Can you see how, see this thing is not moving at all? That is the papillary muscle. So again, this is still an oblique view. On one side you have, see, this is the papillary muscle, this is the mitral valve. So this is an oblique view. And what is happening to the left ventricle in an oblique view? If you think of your loaf of bread, when you have the oblique view, it will neither be rectangular nor long. So see how it's a little bit like an egg. Okay. So what I've rotated too much. So what I'm going to do now is unrotate back to what it was before. Okay. And now see what I've actually got is a papillary muscle view. I wanted a mitral valve view, but I've actually got a really good papillary muscle view. Both sides the papillary muscles are good. Okay. Now to get the mitral valve view, I have to now tilt the probe slightly towards the apex. Sorry, towards the base, and see what I'm going to do here. As I'm tilting up, I'm showing what I'm doing with my left hand, and as I'm tilting up, I'm getting the mitral valve. Okay. Now, if I tilt even more, I get the aortic valve view. Okay. That's the mitral valve. And if I tilt all the way, it's the papillary, I'll get the papillary muscle, and if I tilt even more, I get the apex. Okay? So here what we have done is, by rotating, we have got 3 levels or 4 levels: mitral valve, papillary muscle, apex, aortic valve. Okay? Now that was the long axis view, where the aortic valve was here and the mitral valve was here. Now this is at 3, there are 4 separate levels. Okay. Now, during that, what you should know is, when you are learning, what you will always find is that you will get various different oblique views, and you should know how to recognize the oblique views. So again, let's start off with a long axis view. That's a long axis view. I'm starting to rotate. So this is an oblique view. You can see how the mitral valve is neither long nor short, and the left ventricle is neither long nor round. So as I rotate more, okay, it's become round. It's almost perfectly symmetrical mitral valve, except this commissure is better seen and is a little bit closed and this is fully open. So I'm going to rotate even more, and now it's perfectly symmetrical. Okay, now I'll give you an oblique view of the, we already saw an oblique view of the papillary muscles and mitral valve. So I'm going to recreate that by rotating more. If I rotate more, you can see the papillary muscle and the mitral valve. Okay, now this is an example of the aortic valve and the mitral valve. So that's the aortic valve annulus and that's the mitral valve. Okay, or rather that's the cavity of the left ventricle. So you can see, you can't see the three cusps of the aortic. Okay, so now you can see the three cusps of the aortic valve. This is a good aortic valve level. But if I just tilt in between the two levels, I've got the aortic valve annulus but can't see the valve. And here I can see the mitral valve annulus but I can't see the valve. So it's in between. So to complete the mitral valve, I have to tilt more towards the base of the apex, and here is the mitral valve. But it's an oblique view. Can you see the papillary muscle? Then between the papillary muscle and the apex. So this papillary muscle is really big, this is really small. Again, it's not symmetrical. By rotating, they both become equal. Okay? So by rotating, I'm causing them to be equal. And this is an example of in between papillary and apex. So a little bit of the papillary muscle, a little bit of the apex. So I have to tilt even more towards the apex. So these are various oblique views. When you do your scans, I want you to deliberately get oblique views as well and label them as oblique views. Now, for the apical view. View is the apical apical view, not just four chamber. Now, in the apical view, what we are going to do is to just use my card to explain. So if I sit down here, okay. So that's the heart there. Now, what we have got so far is a view from the base of the heart from here. Okay, long axis of the left ventricle, long axis of the right ventricular inflow tract, long axis of the right ventricular outflow tract. Then we rotated and got a short axis of the left ventricle, and of course the right ventricle also will be seen. So that's along the aortic valve here, the mitral valve which is a little more apical, the papillary muscles which are a little more apical, and the apex. Okay. Now we are going to get the heart in from a completely different window. This window is called the apical window, and it's called apical because it's over the apex of the left ventricle. Okay, so what you should do is you have to locate the apex of the left ventricle, and then you have to scan from below the apex or inferior to the apex, not on the apex. So if that's the apex of the left ventricle, you want to be scanning from just below. Okay, you don't want to be scanning from here, because if you're scanning from here, it's almost like a short axis. Okay, it's called a foreshortened view. Okay, now the various ways textbooks sometimes say you palpate the apex. Now, when you have an ultrasound probe, why would you palpate the apex, especially if your patient is 250 kilos? Okay, you find or you locate the apex, and the best way to locate the apex is by once again mapping the heart. So what you want to do is, if that's the cardiac border here, my pen is not writing anymore. So if that's the cardiac border, what you deliberately do is you start from a point, just like with the long axis or the parasternal long axis, where you started high up and went inferiorly. Here you're going to go, what I do is I go really laterally. You can, I think this might be a better camera angle. Okay. What I'm going to do is I'm deliberately going to go to the abdomen. Okay, so that's the diaphragm, I think. Okay, I'm going to go to the abdomen, get the spleen, for example, and then go up laterally. So I'll be going from abdomen to lung. Then I'll come back and start again, but this time I'll go a little bit more medially, and again lung. Then I'll come back, start a little bit more medially, and here part of the probe will be over the heart and part of it will be over the lung. Then I now know and which and now I'll come back to this direction, okay, and here the first structure that I will get is the heart, is the left ventricular apex. Now I forgot to mention the apical view is a coronal view of the heart. So what you're doing is, if that's your loaf of bread, you're actually cutting the heart in its coronal view. So you have to hold the probe like this, okay, and the probe marker should face the left side, so maybe the 2 o'clock position or the 3 o'clock position, okay. So that's what you're trying to do. So let's start. You want to scan from this side, or 1 minute, I'll actually change the, let's start now. So I'm going to start, as I said, over the abdomen. See, that's the spleen, okay. So I don't know whether you can see, Gunavan. Okay, that's the spleen. Okay, now I'm going to, so if I'm over the spleen, obviously the heart must be somewhere here. Okay, so now I'm going to go laterally. Okay, now I'm beginning to get the pleural line and a B line here. So you have lots of B lines. You need some fusimide diuresis and CPAP, maybe intubation. Okay. Go up, see, lung. Again, lots of B lines. So this is all lung. And then I'm going up. So along this arrow, it's all lung. So what do? I come back. I know that here, I'm not having the heart. If I'm having the lung here and the abdomen here, the heart must be more medial and superior. So now, again, same probe direction, which is about 2 or 3 o'clock, but I'm going to go a little bit more medially along this arrow. So here, as I'm going up, again, lung. Okay, lots of consolidation, collapse. I think he has ARDS. Should do a recruitment maneuver. Okay, coming back, again, spleen, go up. Okay, still no sign of the heart. I've gone all the way up, no sign of the heart. So come back. Maybe he doesn't have a heart. Okay, maybe your wife will confirm that. Okay, then go up. Now, so I'm going even more medially now. Okay, going up. See, now I can see the heart in this. See, I can see the heart in this edge, in the anti-probe marker edge. Okay, and in fact that's the right ventricle. Okay, so now what I'm going to do is, okay, I'm just going to go up and come back down, and now I know I have to go a little bit more medially. So spleen again, so going back down and going up. So somewhere here, okay. Now I can see the heart much better, okay. Now always one important thing, when you are at the parasternal short axis, the depth that you need is only about 8 or 10 centimeters. Apical 4 chamber, again think of the loaf of bread, it's the long slice, so you need a greater depth. And here I can't see, I can only see up to the atrioventricular valves, the tricuspid and the mitral valve. So increase the depth, okay, that's the descending thoracic aorta, okay. And then what I do is, here I can see that the atria are collapsing. So what I do now is, if you focus on my hand, and okay, I'm slowly going to angulate a little more anteriorly, so like that, and see now it's opening up. If I angulate even more anteriorly, or tilt even more anteriorly, I will go even more anterior and the aortic valve will start appearing. This is called the apical 5 chamber. Okay. Now, in an ideal 4 chamber, you will have, if you place the cursor, it should be over the interventricular septum and the interatrial septum. Here, my cursor, the middle of the probe, is over the apex of the left ventricle and the cavity of the left ventricle. So, the interventricular septum is more medial to the probe. Okay, this is lateral, this is medial, because this is where the probe marker is. Therefore, what should I do? I have to go just 1 millimeter more medially, because just imagine That's the middle of the probe, and that's all. I can already see one part of the probe over the interventricular septum. So the amount of that I should move is very little. So see, if I move just a little bit, I'm bringing the probe to the, I'm bringing the interventricular septum to the middle. This is a 4-chamber. Okay. Then the 2-chamber view. Firstly, center the probe over the left ventricle. So here, second, using the right hand, so I'm holding the probe with my left hand like this. Using the right hand, I'm slowly going to rotate the probe. This is the apical 4-chamber. I'm going to rotate the probe anti-clockwise so that the probe marker faces anteriorly. So what you can see anterior, superficially will be anterior, and what you will see deep is not posterior but inferior, because there is no posterior wall for the LV. Okay, so now let's start doing that slowly. I'm going to tilt. Sorry, I'm going to rotate, and as I'm rotating, that structure in the middle of the screen must not disappear. Okay, all that should happen is this structure, which is the right ventricle. So let me go back to the 4-chamber. Okay, this structure is on the right, is on the anti-probe marker, the medial edge of the screen. As I am rotating, I'm going to rotate, and my scan will go through these 2 chambers. So this should disappear. Okay, this will be there. Now the shape of the left ventricle in the 2-chamber will be exactly the same as that of the 4-chamber. The important thing is there are 2 different walls. Here, this wall is the interventricular septum. This wall is the lateral wall because it's facing laterally, okay, like this. When I rotate, all of a sudden, the wall that will come here will be the anterior wall, because that's where the probe marker is. And the one that comes down is the inferior wall. So let's start rotating. Slowly, slowly. As I'm rotating, look at the right side. The right side will slowly, slowly, slowly start disappearing. And although the left ventricle looks the same, see, I've rotated too much. If I've rotated too much, that is called that's the aortic valve there. Can you see that? And this actually looks exactly like the parasternal long axis. Chris, you might actually, if you show the video this way, that looks exactly like a parasternal long axis. This is called the apical long axis view. That's the aorta, that's the aortic valve, that's the LV, that's the left atrium, that's the mitral valve. So if I take this, so this is called the apical long axis, and this is the exact same plane as the parasternal long axis. What I'll do is I'll get the apical long axis. This is the apical long axis, and if I move the probe towards the parasternal in the same planes, that's the parasternal long axis. Okay, I'm going back to the apical long axis from the apex. Okay. Here. Now I've rotated too much, so I'm going to unrotate, and I'm getting rid of the aortic valve, and that's your apical 2-chamber. Okay, so now the 2 walls are, this is the anterior wall, because see, this is the probe marker here facing. This is the anterior wall, and this thing here is the inferior wall. Okay, and here this structure here is actually the thoracic aorta. Okay, because the thoracic aorta is going to come from, where's my pen? The thoracic aorta will come from here, and then it's going to come in the left side of the midline here. So that's why the thoracic aorta is in its long axis here. Okay, this thing. Okay, now again, just like with everything else, you can have oblique views. Okay, so let's get some oblique views deliberately. So firstly, oblique view of the apical 4-chamber. So if I have, so I'm going deliberately over the spleen. Deliberately over the spleen, going slowly up, okay, and then I get so here I get a little, I know that this is the beating heart here. Okay, firstly, not an oblique view, I'll get a foreshortened view. Sorry, firstly I'll demonstrate the foreshortened view because this is very common. Now here, ideally for the apical forechamber, you want it inferior to the apex of the left ventricle. So somewhere here, okay, that's inferior to the left ventricle apex. If I go on the left ventricle, see how the shape is going to change. So firstly, okay, this is a good view, okay, and if you look at the apex of the left ventricle, I'm going to zoom all the way to the apex. See how the apex is you can hardly see the apex.
Yeah.
Okay, it's quite thin and it's actually not contracting much. If I'm on the apex, it's called a foreshortened view. Now for that I'm going to go even more towards the base of the ventricle. So see how it's become round, okay, and when that's the first thing. And second, see how the apex has become quite thick here. I'll increase the gain so you know. The apex has become quite thick, and see how vigorously it seems to be contracting. This is called a foreshortened view. It is on the left ventricle. Although you can see 4 chambers, you can see the apex too well and it contracts too well. This is not a good view, and the reason it's important is because look at the right ventricle size compared to the left side. It's almost the same. People can think that the right ventricle is dilated, and I've had a registrar call me in the middle of the night saying that the right ventricle is dilated, the patient is hypoxic, they think it's a pulmonary embolism and they wanted to thrombolize. What they had was a foreshortened view, and what you should do is go inferiorly in that same angle axis, okay, and now all of a sudden that foreshortening is gone and you have a long and not dilated right ventricle, okay. And here you should not, and you are not able to see the left ventricular apex contracting. So this is a very, very important thing. Same thing, I want you to deliberately get a foreshortened view. Second, some oblique views. Okay, I am rotating. Okay, this is, see how everything is towards one side. Okay, so interventricular septum, all of them, instead of being in the middle like this. Okay. Now, this is where you want the interventricular septum to be. The interventricular septum is here. Why? Because I am actually, the probe marker is looking at the left shoulder in this instance. So what do? I straighten the probe marker and make it look at the interventricular septum. Third, it's very common for the left atrium to collapse. Okay, this is one chamber, second chamber, third chamber, but you can't see the fourth chamber. So this is an apical 3.5 chamber kind of thing. What should you do? You have to just tilt the probe anteriorly or posteriorly. In this instance, I'm going to start tilting the probe a little bit anteriorly, very gradually, and see how that left atrium is beginning to open up. If I do it more, the aortic valve will come. That's called the apical 5 chamber. The aortic valve is considered to be the 5th chamber, the aorta. So you don't want that. So you go back a little bit more posteriorly, and this is your apical 4 chamber. Okay. So again, this is a collapsed 3.5 sort of chamber, okay, and then what I'm doing is I'm going to slowly tilt a little bit anteriorly, and that's the apical 4 chamber, okay. Then for the 2 chamber, the oblique views, as I'm rotating slowly, I can get any number of, so this, I haven't rotated far enough because I still have the right ventricle somewhere here. Okay, can you see that?
Yeah.
So I have to rotate even more, and now I've got the apical 2 chamber. So this is how you get the apical views. Okay, we'll go to the subcostal. Okay, for the subcostal view, again, the subcostal view looks at the same heart from the right side, from the abdomen, and we use the liver as a medium for the ultrasound to go through. Okay. So there are two views for the subcostal. The 4 chamber view is also a coronal view like the apical 4 chamber. So with the apical 4 chamber, we get a coronal view from the apex. Here we get a coronal view from the right side. What you should do is, with the subcostal, there is not much of a movement. You just keep the probe in the xiphisternum. So that's the xiphisternum. So just below that. You go slightly to the right side of the xiphisternum rather than to the left, because On the left side, you have stomach, which may have gas. On the right side, you have liver, which is vascular. And it allows the ultrasound beam to go through. So, now how you hold the probe for the subcostal is, you should not have any part of your finger under the probe. Because you need to almost angle the probe on the patient's abdomen. So you hold all parts of the finger, everything will be above, will be on the superior surface of the probe, nothing inferior. So holding, and then the probe marker will face the right side. Typically, it will face somewhere between the 3 o'clock position and the 4 o'clock position, because that's where the heart is. So this is how you're going to scan. Okay. So I call it the dip and the tilt method. So what you do is you first keep it on the probe, on the abdomen, get the liver. Okay, now that's actually gut. Okay. Nice peristalsis. So I'm going to, that's the liver. So I'm gone slightly to the right side, and that's the liver. That's your portal vein there. Okay. Then slowly I dip inside, and I tilt, slide slowly towards the heart. And the heart should start appearing as I'm tilting. See?
Yeah.
Here. Now see how deep it is. Because the heart is very deep from the subcostal plane. It's somewhere here. So it's already 15 centimeters and you can't see. So let me increase the depth. And now as you tilt, and then what you do is you actually have to push the probe in to get more of the heart. Okay. And then as you're pushing the probe in, you also have to go under the sternum and skim the under surface of the sternum. Okay, if that's the sternum, you actually you want the ultrasound beam to just go under the just deep to the sternum. Okay, so once again, right side liver. Okay, then get it perpendicular, get the liver, then slowly start tilting the probe and dip under the sternum, and the heart should come into view. Okay, and that's and then what you do is you can't do much movement here because you're stuck in that area, but what you can do is you can actually rotate a little bit and make an oblique axis a longer coronal axis. Okay, so that's the right ventricle, that's the left ventricle, that's the aortic valve. If you're getting the aortic valve is anterior. If you think of your parasternal long axis, the aortic valve appears anteriorly, and that's the mitral valve. So if you want the 4-chamber view with mitral valve, you have to tilt a little bit more posterior, just a little bit. Okay, so that's how much you tilt. Okay, and I'm not able to get a real. I'm going to move a little bit more towards the right side to get rid of the stomach, because I think everyone has had a nice lunch. Stomach is full. Okay, right ventricle, left ventricle, right atrium, tricuspid valve. I'm not able to really see the left atrium very well. I'm going to rotate and see whether I can open it up. I can see that's the mitral valve now.
Yeah.
Okay. Now, for an advanced, slightly more advanced thing, you can get the same parasternal, you can get the same short axis views from the subcostal view. So, see, this is the short axis, 1, 2, 3, 4. If you think about it, you can send the same axis from here, 1, 2, 3, 4. So what I'm going to do is, I'm going to slowly, now that I'm having the probe marker facing anteriorly, okay, and the beam is now going towards the apex of, in this instance, the apex of the ventricle. That's the right ventricle, that's the apex, that's nice and round. That's a short axis view. And that thing there, I think, is the mitral valve. I can see one leaflet of the mitral valve, I can't see the other. So now what I'm going to do is, if I want the apex, I have to sweep the probe towards the the arm here. And if I want the aortic valve, I have to go towards the clavicle. So if I sweep from, see, the left arm towards the clavicle, step by step, I'll go from the apex of the left ventricle to the papillary muscle, to the mitral valve, to the aortic valve. Okay. So now let's start. This is somewhere in the left arm. Okay. That's the apex of the left ventricle. That's the liver, right ventricle, left ventricle. I'm now going to go slightly towards the left shoulder here. I've already got the mitral valve, so I'm going to go back towards the left arm to get the papillary muscle. I'm not really getting a good papillary muscle view, so I'm going to just abandon it for this, but that's the idea. Then I go back, see that's the leaflet of the mitral valve, and now I'm actually here, I'm aiming here towards somewhere near the clavicle and lateral edge of the clavicle, and then I'm going to tilt even further towards the medial edge. See, that's the pulmonary artery. That's the pulmonary artery. It's the exact same, and that's the aortic valve there. Okay, that's the right ventricular outflow tract view that you will see in the parasternal short axis. I'll go back to the parasternal short axis to demonstrate that. But that's the right atrium, that's the tricuspid valve here, and that whole thing is the pulmonary artery, and this thing in the middle is the aortic valve. Okay, and here the axis is here, somewhere here. Okay, now if I want the same thing from the parasternal view, okay, so here, this view, let me just take the probe all the way there and keep it here and attempt the same thing from here. That's the mitral valve. Okay, let me decrease the depth. That's the tricuspid, that's the RA, right atrium, that's the tricuspid valve. This is in between the mitral, aortic and the mitral. So firstly, let me get the aortic valve view by tilting a little bit more anteriorly, and as I'm doing that, I'm going from the oblique view to the proper view. And here what you'll see now is RA, right atrium, tricuspid valve, and that's the right ventricular outflow tract, and that structure there is the pulmonary valve. This is the pulmonary artery. Okay, here. See, now I'm getting it here from the from the subcostal. We got it from here. Okay, it's almost the same. We got a much better shot of the pulmonary artery. It was nice and long from here. So let me just try and rotate the probe and see whether I can get the pulmonary artery better. Slowly, this is the mitral valve view, aortic valve, which is I'm tilting, and that's, I'm not really, here I'm not able to get it much well because you can see that the lung is coming laterally. From here we could get a much better pulmonary artery view. There is no, there was no interference. Okay. The depth, see, you can see the pulmonary artery beautifully. From here, you have a little bit of the pulmonary artery. You have a little bit of the pulmonary artery here, but the lung is coming in the view. See, that's the pulmonary artery there. And I'm having the A lines, so that's the pulmonary artery there. Okay. Where is the IVC? IVC, the two iliac veins will join somewhere here, and then the IVC will come slightly towards the right of the midline. That's your liver here. Okay, that's your liver. The IVC will come slightly towards the right of the midline. Okay, and then it will join the right atrium here. So what we want is the IVC in its long axis. So how will the probe be? How should you? What will be the plane?
Sagittal.
Sagittal. Beautiful. Parasagittal. Okay. So when you do the subcostal view, I showed you the subcostal. So increase the depth again. That's the liver. Okay. I showed you the subcostal long axis, this one, and then I showed you the subcostal short axis, which you get by rotating gradually. The extreme rotation towards the right is the IVC view. So why now, as you're coming there, okay, so that's the right atrium, okay, that's the right atrium. As I'm rotating slowly towards the ceiling, I should start getting the IVC somewhere here. And remember, that's the plane of the IVC. So now what I'm going to do is, I'm just going to scan medially to the right side and the left side. And what you want to do is to see the IVC entering the RA through the liver. Okay, see there, there. That thing there is the IVC. Now you want the whole of the IVC. So I'll just put some color for you to be able to see. That's the hepatic vein that you could see. Okay, you want the whole of the IVC to come. Okay, now if you are a little bit oblique, so if that's the IVC and you are oblique like this, you will cut off part of the IVC. And depending on which part you have cut off, you have to rotate that way. So if you are oblique in this direction, you will be cutting off the inferior edge of the IVC. You may be able to see the superior part entering the right atrium, but the inferior part that's going through as the liver and the abdomen will be cutting off. Okay, so once again, get the 4-chamber, slowly rotate the probe, and as you're rotating the probe, you should start seeing that IVC entering the right atrium. Okay, so there, that one. Okay, now I'll rotate even, sorry, my bad. Sorry, it hurts, I know. Okay, so that's the IVC entering the right atrium. But I can see the right atrial side well, but I can't see the inferior. I can't see the inferior aspect, the abdominal aspect of the IVC. So what should I do? I have to slightly, in this instance, what I'm doing is I'm sweeping the probe slightly to the right, and see, I'm now able to open the whole of the IVC through the liver. Okay, that is what you must want. That is what you want. Okay. Now, one very important thing: the aorta is on the left side, and the difference, and it will look exactly like the IVC. It will be nice and long. Okay. You can't depend on pulsation because sometimes the IVC will pulsate because of the aorta, transmitted pulsation of the aorta, or because of tricuspid regurgitation. What is important is the aorta will be behind the heart, the IVC will enter the heart. The IVC should enter the RA, the aorta will be behind the left atrium. Okay, so let's see. Now that's the IVC. Now I'm deliberately going to go to the aorta will be on the left side of the midline. Okay, so I'm slowly going to scan to the left side of the midline, and I should be able to see the aorta. Just a second. There, that's the aorta, and the aorta will not enter the, see, the whole of the aorta is posterior. See?
Yeah.
It's posterior to the heart. Okay? You are not, because you are not seeing the origin of the aorta. This is the abdominal aorta and the descending thoracic aorta. So you should not get confused between this and the IVC. Okay? Now if I'm going to, if I slowly go towards the right side, I'll actually see that's the IVC and that's entering the RA here. Okay, got it? This is the superior, this is the thorax, this is the abdomen. Okay.